We have a jam-packed afternoon, and I'm really delighted to start off the afternoon session with a topic that's on everybody's mind. As you've been hearing all week, health equity is really at the center of our core values. And in fact, last year at the annual meeting, the talk that Pascal White gave related to healthcare disparities was probably the most highly rated talk of the meeting. So there's a lot of interest in this, and we thought it might be an interesting change of pace to make this more of a casual conversation. That's why the chairs are up here. We haven't done this before, but I think we'll see what you think about it. We live in a very racialized society, and biases come up all the time. And many of us have thought about, even trained about implicit bias, but we need to keep it front and center with everything that we do. And I'm really very pleased and proud that Shana Ntiri from the University of Maryland has taken time out of her busy schedule to be with us today. So Shana is assistant professor in the Department of Family and Community Medicine and also the medical director of the Baltimore City Cancer Program. And we're also very, very pleased that Paula Chambers Raney is here. She's a survivor and a thriver who does a lot of work for Fight CRC, and she'll be telling us her story. So we'll hear it from the sort of the medical profession side, and we'll hear it from the patient side. And then there's lots of time for questions and comments, so we do hope that you'll chime in and ask questions afterwards. So Shana has a few slides to sort of introduce things. There's going to be a couple of poll questions. After that, it's all, then we'll let Paula speak, and then it's all informal. So Shana, thank you very much for joining us.
All right, and slides are queued. Wonderful. Part of this talk is going to be, can you get through the technology? I think I'm ready, though. I thank you to everyone for the support. Get through the technology after lunch, correct? It is an absolute pleasure to be here. Looking forward to our continued conversation. Living room, Steve said it's living room style. I said, well, where are my snacks? All right, again, I am from just down the road. I said I probably had the shortest commute here. My office is 0.7 miles away, so yeah, I did pretty well, right? For everyone else who had to come to the airport, really not far away at all. So I am a mom of 3, and my kids are relatively young, so just going to keep this very simple. As Steve said, I'm sure many of you have had conversations on implicit bias before, so I'm going to focus on the 5 W's, although my kids would say there's an H up there, but still, we get it, the 5 W's. So what is implicit bias? Who does implicit bias impact? Why should we address implicit bias, and where are the impacts of implicit bias seen? And really, I think what the charge for the afternoon is, how do we address implicit bias in healthcare, and specifically in the context of colorectal cancer? So here you go. This is to make sure you guys stay awake. Everyone wants you to pull out your device, either your phone or your laptop. Going to have you go to the Slido website and enter that code. It's getting you guys warmed up for the technology, but also just to see where folks are. All right, look at this. Well, that's just 2 people. I was going to say, okay, all right. We're at 4. Let's see where we go. It's fun. It's live, right? And I don't know if this is going to time out or if we keep going. It looks like we're at 66, 72, 81. All right. Things keep changing, right? The ever-changing forefront. All right, so it looks like folks have had their afternoon caffeine, they're ready to go. Some of you are still trying to adjust to being in person, right? As opposed to all those virtual meetings. I always say the 3D versions of people are better. To be determined, we're gonna try to keep you here with us. And there is someone who went for a run during lunch. I had my first meeting back in person was not too far away from here in Baltimore, and got up and it's like, how are you doing? I'm like, I'm tired. And the person I was speaking to was like, I was up at 5 and I ran through the Inner Harbor and it was great. And I said, well, that is not me. So Here we go. So perspective on implicit bias. So implicit bias training or conversations really are meant to be ongoing, right? It is our individual charge or organizational commitments to not just a checkbox compliance activity, but really to think about how we can continue to evolve and make sure we keep this concept at the forefront in order to do our best. So a case, just to give you a little bit of context, a case for consideration. This is a fictional character, but she may sound like a real person to many of you. DW. So DW is a 52-year-old African-American female who's got a past medical history of diabetes and hypertension, obesity with a BMI of 37. She arrived at her appointment 14 minutes late today. I count that because in my office, when you're at 15 minutes is when you're counted as a no-show. 14 means you're sliding in. Basically, you've used your appointment time. The medical assistant reports that DW has not received the COVID vaccine, and she refused the vaccine when it was offered during triage. Review of her EMR documentation. We've talked about EMR today, and DW's chart includes the following. Despite multiple conversations with providers and a family history of first-degree relatives with colorectal cancer, the patient is resistant to completing colorectal cancer screening even after multiple colonoscopy referrals to the local no-cost cancer screening program. She's up to date with breast and cervical cancer screening. So, just want to make sure that we're all on the same page in terms of the different terms that we're using. So back to those devices again. Which one of these do you identify as the definition of implicit bias in healthcare? The first is differences in opportunities to achieve optimal health vary by populations and communities, or differences in length of life, quality of life, rates of disease, disability, death, and access to health care, beliefs and prejudices that reside outside of our conscious awareness and impact health, or all of the above. All right, we'll see the live action changes here again with Slido. We'll give folks a little bit of time to respond. All right, we're at 112. It's still going up. And so with the majority of folks saying all of the above, followed by beliefs and prejudices that reside outside of our consciousness awareness, differences in length of quality of life, and then differences in opportunities. And actually, I'm going to advance to the next slide and show you that implicit bias is actually beliefs and prejudices that reside outside of one's individual consciousness and awareness. So just to go through the terms again, I think a lot of these terms are kind of used interchangeably, and it is important that we know what it is we're speaking about. So first was health disparities. So health disparities, these are definitions from AHRQ and CDC. Obviously, you get slight tweaks depending on who your reference is. But health disparities defined as differences in opportunities to achieve optimal health varied by populations and communities. So that's health disparities. Health inequities, differences in length of life, quality of life, rates of disease, disability, death, and access to health care. Implicit bias, again, is beliefs and prejudices that reside outside of our conscious awareness and impact health. So there is a distinction with these terms. And really, if you think about what implicit bias is and how it helps us, there's stereotypes, right? We all are processing a lot of information. This meeting is no exception. You're trying to get information, process it, figure it out, and figure out how to apply it. And so stereotypes allow us to process large amounts of information and group, particularly when we're looking at folks by gender, race, ethnicity, sexual orientation, weight, religion, et cetera. The problem with this is obviously if you do that, you can overgeneralize and attribute inaccurate information to individuals based on these categories. So, who does implicit bias impact? No clickers this time, just shout it out. Let's hear a couple of things before I pull in my answers. Who does implicit bias impact? Perfect. Perfect. I love it. We're there. You guys said you weren't sure. I'm like, no, that sounded like almost 100% of the room. So patients and caregivers, right? Healthcare providers and support staff, employers, administrators, policymakers, everyone. I think the important thing to recognize with that is that if everyone is impacted, then that also means that our infrastructures, right, our systems are also impacted. I was at a meeting with an individual who said, I don't think that this is something that impacts my organization. I think we do well. I think we've been conscious. And I asked the question, well, who is sitting at the table to make those decisions? And it's not to say, again, that if you have representations, you'll get that broad spectrum. But if you don't at least have diverse participants participating in those conversations, then there likely is bias, because we all bring bias to the table with us, right? So implicit bias, researchers show that all people have implicit bias, and individuals' biases are based on their individual experiences and perceptions. Physicians are no different. When they look at physicians compared to the general population, physicians have as much implicit bias as a person sitting next to them. And so it really is important that we are aware of this and try to address. So why? Why do we care about implicit bias in healthcare? Because implicit bias contributes to health disparities, right? And the outcomes that we're talking about. Poorer patient outcomes. Increased provider bias is correlated with poor patient-provider interactions, so we've had some conversation about the importance of communication. Implicit bias impacts clinical decision-making and influences even diagnosis and treatment decisions. So really, it's important that we address these differences. There's one study that looked at 10,000 providers. These were physicians from every specialty, from family medicine, pediatrics, endocrinology, trauma surgery, ER, oncology, the list goes on. And they looked at pre-health students through attendings, physical physician assistants, psychologists from big cities, Baltimore being one, Denver, New York, Detroit, Seattle, the list went on. And what they found was that most providers, regardless of their level of training, have implicit bias against Black, Hispanic, American Indian, and darker-skinned individuals. They also found that providers who are more likely not to demonstrate implicit bias compared to whites is African American providers. There really isn't as much research on terms of what the impact there is in terms of implicit bias, but I think we know that potentially it does have an impact. So again, why? To address implicit bias, it's also associated with a lower sense of adherence, right? So we were talking about trying to get that to that 80%, that we want to make sure that people are screening. But if patients perceive that there may be bias in a provider, that in itself may be a reason that they don't adhere to physician recommendations, even if these are evidence-based guideline, or, which we know is very important in terms of cancer detection and screening, it may lead to delays in care that can have negative impacts upon outcome. So where are the impacts of implicit bias seen in healthcare? They're seen in many ways: in interpersonal interactions, so between patients and providers or physicians, internal dynamics. If you look at the body of physicians in the United States, less than 11% of all physicians in the United States are either African American or Latino, despite the fact that these two groups make up 33% of the population. And why this matters is there's a big body of literature that looks at racial discordance between physician, provider, and patient and the potential impact. And also it leads to waste and cost, up to $310 billion per year just in terms of lost productivity and poor health. These are two examples of implicit bias in trainees, again, talking about what people bring to the table. One study was from 2016. Some of you guys may have heard of this. When I heard about it, I was really surprised. 73% of the sample, which was white med students and residents, endorsed that at least one false item regarding Black patients, that Black patients' skin is thicker than whites and Black nerve endings are less sensitive. Obviously, this has implications for things such as pain management in these patient populations. There was also a weight-based study, and this was a web-based survey completed by nearly 5,000 first-year medical students from 49 medical schools across the country. 74% of students exhibited implicit bias upon weight. And these are obviously not things taught in medical school, but if we're not consciously addressing them, these are things that our trainees will take into care. Another example is around maternal health. There's so many examples if you look to the literature, but these are definitely important things. And I always like to highlight these two faces because I think when we talk about health inequities, when we talk about health disparities, when we talk about implicit bias, you start to kind of get a picture of what the patients who are impacted might look like. But these are two faces of physicians that many of you may know. The first is Dr. Susan Moore, who is a physician who posted a video on Facebook after receiving what she described as racist treatment at Indiana University, her own university, and she ultimately died from COVID. There was an independent study into her care and her research that said that her care lacked empathy, compassion, and awareness of implicit racial bias. So she lost her life. as a physician, right? A physician knows how to advocate. There's no health literacy issue there. There's no gap in knowledge. There's no understanding how to access care. So I think that's important. The second picture is Dr. Shanice Wallace. She was a pediatric chief resident at her institution who died shortly after an emergency C-section that was being done for preeclampsia. Again, her and her husband were advocating that she needed something to be done, and she ultimately died. So the other example I often talk about, which many people have heard, is Serena Williams, right? Like, I'm like, if Serena Williams ever walked into the room, I'm just like, bow queen. What is it that you need? But even she, when she had her baby, speaks about the fact that she had to push back and advocate for the care she needs. She is an elite athlete. She knows every inch of her body, right? So she says something is wrong. Something's wrong. So just some examples to keep us thinking. Implicit bias in cancer survivorship. Minorities are less likely to receive specialty referrals for things like lymphedema management or fertility preservation before initiation of treatment. Incomplete communication, so shorter interactions, less in-depth explanations, and more anxiety-related words from the physician, which may then provoke anxiety in the patient and impact how they receive the information. Underassessed and undertreated pain, so we talked about the perceptions about pain, leading to less likelihood that they'll receive opioid analgesics or appropriate treatment for cancer-related pain, and differences in overall prognosis related to the diagnostic and treatment differences, which means one example of this is that they may not be referred to clinical trials because people say their prognosis isn't good anyways, and so you just kind of stop short of opportunities for them to do better. Race-based calculators in medicine. This was a study that came out in the New England Journal of Medicine in 2020 that looked at the use of race in diagnostic algorithms in the practice of medicine. And really the authors challenged physicians to think about the fact that if I asked all of the physicians and providers in this room to define race, none of us would come up with the same definition. So we're taking a very subjective term and applying it to very objective algorithms, and that in itself is problematic. So these calculators, again, are used, and there are many, 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 many used in medicine to individualize risk assessment and to guide clinical decision-making, which may direct attention to white patients in comparison to other ethnic and minority groups. So I'm a family doc, I'm in primary care. One that I would think about is like the ASCVD calculator, which is used all of the time, but gonna highlight a couple of calculators that are used in cancer, so ones that I'm not so familiar with, but I figured were more relevant to this crowd. So the race-based calculators in cancer treatment, so the rectal cancer survivor calculator, again, looked at the prognosis after diagnosis of rectal cancer, making the prognosis worse for African Americans, then again saying that, again, we may stop short in terms of the spectrum of treatment that's offered to a patient. The NCI breast cancer risk assessment tool, which is, again, trying to identify those who are at highest risk. We talked about the importance of knowing about patients who are at higher risk for breast cancer, but this, again, may skew towards favoring individuals who are white. And the Breast Cancer Surveillance Consortium risk calculator is another one that's highlighted. It's an interesting article if anyone has any interest in looking at it. If you just look up race-based calculators, New England Journal, you'll be able to look through it and see if there are any calculators that are used in the context of the work that you do. So internal dynamics, negative EHR descriptors, again, thinking about our patient DW. This was a study that looked at histories and physicals for nearly 20,000 patients seen between January 2019 and October 2020. And they looked for 15 specific descriptors, using the words refused, non-compliant, challenging, or unpleasant in terms of description of the patient behavior. And what they found were the odds of at least one negative descriptor in the EHR documentation were increased for certain groups. So Black patients had a 2.54 increased odds versus white patients, Medicaid patients a 2.66 versus Medicare versus 2.08 increased odds versus patients who were insured either privately or had employer-based insurance, and unmarried patients a 2.12 increased odds. So there are many groups that they looked at, but just highlighting some of these. And the study highlights the potential impact of stigma within the EHR in terms of future patient care. This said that as little as 18% of inpatient documentation was original, not copied. So that's a very low number. When you hear it, it's kind of like, what? But if anyone works in the EHR, you know, when the patient comes into the ER, they document, and then people just borrow snippets as they continue to go through. And so if that, initial patient interaction was between an intern who has seen no sleep for a long time and is just getting over COVID themselves, and a patient who's coming in the door and upset, it might be not the best patient-provider interaction, but that the context or that perspective can carry forward with a patient's chart forever. The EMR doesn't go away. It's there forever and ever. So negative descriptors were found less often in outpatient encounter documentation. They didn't speak to that, but I'm guessing in the outpatient setting, oftentimes there's a relationship, a more long-term relationship between the provider and patient. More needs to be understood about the long-term impact of negative descriptors, but the thought is negative descriptors, stigma, compromised care. So how do we address implicit bias in healthcare? Patient-centered interventions, and I think as we move to our next conversation, we will talk about some of these things. But the important thing is treating each and every patient as a unique individual. Obviously, that population health perspective is very important, but when you're interfacing with the specific and individual patient, recognizing that patient as an individual, screening for and addressing the social determinants of health. We, again, spoke to some of these things. Some of the barriers may be because a person doesn't have access to transportation. So as much as possible, using patient navigation and other resources and tools that we have in order to make sure people are getting optimal care. And utilizing patient expertise, patient advisory boards. I think this is a group that gets it, right? You need to have all stakeholders at the table together having those conversations, but it really is important to bring those voices into the healthcare system as well. Provider-centered interventions, implicit bias training, I highlighted this, mindfulness-based practices, because at the end of the day, if you are tired, right, if you go into interaction and you're exhausted and you're not taking care of yourself, that has potential implications for the patients that you're taking care of. Adoption of patient-centered care, open notes. So this was legislation that came out saying that automatically all documentation in the EHR is available to patients. There are a lot of folks in my system who I say got really nervous about that. And I was like, you might need to look in the mirror and figure out, why are you so nervous? What do you think is gonna happen when your patients see these notes, So anyways, reevaluating standards of care, the use of race-based algorithms or other embedded tools, and identifying and addressing internal inequities in terms of salary, promotion, hiring, leadership, those types of things. This is a quick, in case you're still hungry, looking at the quack, 3 levels of socially accountable care. I'm looking at the micro, the meso, and the macro, basically saying that we need to approach this from all angles and every level of care. These are 2 screenshots from my email. One is dated January 31st, 2022, and the other one came out after that. This was from our healthcare system and the University of Maryland. I had it here. I think people may know, but I went to Dr. Google to see how big is this healthcare system. So founded in 1984, 13 hospitals in Maryland, over 2,500 licensed beds, about 130 annual admissions, and gross patient revenues of $4.4 billion annually. So you get it. It's a big healthcare system. Well, there was a small group of DEI champions that went to the leaders of the system and said, listen, we are using race-based calculators. This is not the best way to go. And so these are the emails saying that, 1, the racially based GFR calculator was being taken out of our EMR system. It no longer exists. Another system was being put into place. And the second was the vaginal birth after cesarean calculators. That was also removed from the system. So these are the first of 2 of race-based calculators in the system that have been removed. And I highlight these examples because it was a small group of determined folks who got the work done, much like folks in this room. So, summary, implicit bias in healthcare for DW and beyond. What is implicit bias in healthcare? I think we all have a good sense of what that is. And really, it's about just keeping this concept at the forefront of our minds in order to make sure that we optimize healthcare as best we can. Who? We are all key to addressing implicit bias and understanding that this is not a they problem, it is an us problem. Why? There are too many reasons to count in terms of why we need to address implicit bias in healthcare, but the ultimate goal is to improve patient care, right, and ultimately patient outcomes, where the impact of implicit bias in healthcare is so far-reaching, and patients are not the only people impacted. We also in this room. How do we impact implicit bias in ourselves and our work? I think that's part of the conversation that we're going to have moving forward. But we'll give you an opportunity to share your thoughts. Last thing that we're going to have you do on Slido is just speak to what it is that you commit to in order to addressing implicit bias, both in your individual work and the work that's happening within your organization. And as we do that, I'll transition and pass on to Paula. Thank you, guys.
Thank you so much, Shana. So we're going to hold questions for after Paula speaks. So Paula, the floor is yours, and then afterwards we can engage everyone. So please, tell us your story.
Is this on? Hi, thank you, everyone. I'm Paula Chambers Raney. Thank you so much for inviting me to speak today. I'm here basically just to share my story. I am a stage 1 colorectal cancer survivor. And the first thing I want you to know, thank you. The first thing I want you to know is that implicit bias almost killed me. It almost took my life, and the lack of humanity that I was shown during what led up to a diagnosis in our county hospital in the ER, the lack of humanity that I was shown along the way, it almost killed me. And so when I was diagnosed on January 27th of 2015 in our county hospital in Houston, Texas, in the ER, I was told I had colorectal cancer. I didn't know what it was. I kind of had heard of colorectal cancer, and I looked at the 7 doctors that came in the room to tell me this, and I said, I'm pretty sure you're wrong because only old white men get this disease. That's what I thought. That's the information that I had. What happened to me and my wife in the year of 2014 really impacted our lives, and we're still kind of catching up from the hurricane of all the things that happened. But I was sick for an entire year. I had gone from my PCP to emergency rooms to urgent care centers up until about a week before I was put in the ER. I went to my last urgent care. Excuse me, it was on a Thursday. I was put in the hospital on the Monday. On that Thursday, I went to the last urgent care, and I said, ma'am, I can't take this pain anymore. I'm in so much pain on my right side. Nobody will help me. Nobody will give me anything. Everyone keeps telling me I have hemorrhoids, I have IBS, I have this, I have that, but no one's giving me anything. No one's told me what to do. And yesterday, I saw nothing but blood, nothing. I saw red. She said, I'm sure it's not anything wrong. You probably ate something red. She said, I'm going to give you, just in case, this test for your stool. And I'm going to give you a prescription for something for your stomach. And she did a fit test. But she said, we won't have, it's just urgent care. I won't have a way to tell you anything about this, but I'll call you next week. I went home. We got that medicine. I still remember the taste of that medicine in my mouth. And on Monday, I was in the ER, told I couldn't leave. And it ended up that I had a baseball-sized tumor. I was completely blocked. I had to have emergency surgery. And I'm still here today sharing my story. And the reason, thank you. The reason why I do that is because a lot of anger came after that. We went through a lot, and I mean, I was even told by one doctor that I can't help you, because my wife was with me. He's like, I can't help you. I've got to go find somebody else because you're going to hell. And this is all in that same year. I lost my job that year because I kept calling in sick. It was a new job that I had just started. I kept calling in sick because I was. So I had no insurance. So when I went into the hospital, I had no insurance because my wife and I we had just gotten married that year. I managed to get married that year. I was very sick, but I didn't know. I just thought I had lost a lot of weight and looked really great in my wedding dress. I look at those pictures now and I'm like, yikes. But I got married that year, but we were married in New York. When we went home that week, we weren't married in Texas. So I couldn't be on my wife's insurance. It was just a lot of things that went wrong. So after I got out of the hospital and I was healing and trying to figure out how to manage colorectal cancer, something I had to learn about, there was a lot of anger about what had happened. and a lot of time to sit back and remember all the things I was told. And so I had to take that anger and do something with it. My wife helped me with this. She got on Dr. Google, and she found a couple of different support groups. One of them was Fight CRC, and I'm very grateful to Fight CRC. I just want to put that little plug in there because I found a voice and a way to express what I was going through and talk about it in a way that was healthy for me and in a way that I could help other people understand that if this is happening to me, if this happened to me, it's happened to other people. Other people, I don't want to say weren't as lucky. I just know that people have died from this. And I wanted to stop. So that's why I'm here today. This is why I share my story. Implicit bias did almost take my life, but it didn't. So I would like to talk about it, and I would like to see something done about it. And that's why I'm here. Thank you so much for having me.